On is April 2nd, Wednesday, and this is House Healthcare. And we're continuing with testimony on S18. And today we have in with us Secretary of State's office.
Good morning. Thanks so much for having us. For the record, my name is Lauren Hibbert. I'm the Deputy Secretary of State, and it's wonderful to see you all. And I have with me
Jen Collet, I'm General Counsel at OPR. Nice to see y'all.
Welcome.
Thank you for the opportunity to speak about S18. This is a bill that we actually did not talk to on the Senate side. It moved faster than we had the opportunity to get into the committee, so we really appreciate the opportunity to be here today. The Secretary of State and OPR support the creation of freestanding birth centers. We regulate a large majority of maternity healthcare providers, including certified nurse midwives and midwives that traditionally give maternity services to laboring people at home. We regulate, as you guys know, so many of those professions, but those are the ones that are most involved in maternity care. We also regulate naturopathic physicians, which have a natural childbirth endorsement. I believe we have 4 naturopaths who have a natural childbirth endorsement. And osteopathic physicians, of course, there are some who are in the OB space. We also regulate pharmacy, so you'll see in our testimony we talk about that as well. Our regulation of pharmacy involves everything related to storing, compounding, dispensing, maintaining, labeling, that is important. When we're looking at a bill, that is something that we take into consideration. So our understanding is that these birth centers will be for low-risk pregnancies and births, that epidurals and opioid pain medication will not be available on site, and that surgical services such as cesarean delivery will not be available on site. And that medication storage and management that would be similar to a hospital setting where there is the requirement that there be a hospital pharmacy is also not going to be on site at these freestanding birth centers. We do have some proposed amendments, and assuming all of what we've just said is, sorry, Jen. We do have some proposed amendments, assuming that what our understanding is correct. We think that the definition for what is a low-risk birth should be added to the bill, because it says that the freestanding birth center is for low-risk births, but it doesn't define in the bill what that is. So we recommend adding a definition for low risk, and our recommended language is low risk means uncomplicated perinatal care provided to healthy patients during the childbearing cycle, including normal pregnancy, labor, childbirth, and the postpartum period. We also would recommend and appreciate if epidurals and surgical services such as cesarean is expressly stated as prohibited in these centers. And so we are asking for that additional language to be added to 2351(1), section 1. And we didn't put a number on the definition for low risk because your legislative council will handle that very well. So those are our 2 amendments related to low risk, just to be very expressly clear what is allowed and what is not allowed in these birth centers. Does anyone have any questions on that?
Leslie, I just have a question about the hospital part. Like, should a hospital decide to create a freestanding birth center off-site from where they are? Is that possible or not possible?
That would be possible, but there would still not be surgical services.
Yeah, totally get that part, but it's still legitimate for a hospital to say there's a potential market or something.
I don't see any reason why that could not happen under the structure of this bill.
Thank you. I'm starting to conflate together, but isn't there something in the language that freestanding birth centers were not affiliated with a hospital or?
They don't have to be.
Yes, so the definition of a birth center is, says it is not, does not include a facility that is a hospital, is part of a hospital, or is owned by a hospital.
So we can't, so a hospital could not do that.
I'm sorry that I missed the initial question.
I was just wondering if a hospital thought this is a great idea, because there's this gaps, maybe we could fill the gaps. So I was wondering if a hospital could decide to support or whatever a freestanding birth center.
I think that would be, I think a hospital could, but not, it wouldn't be licensed under this chapter. It would be part of the hospital.
Different chapter, I get it.
Yeah.
Thank you.
Offered by the hospital.
Mhm. Thank you.
Yes.
Doesn't Copley have a birth center?
It's not a freestanding.
Oh, okay.
I have a question around your adding a birth center does not offer epidurals or surgical services. Lots of things can be considered surgical. I'm thinking of things like sutures or I mean, technically, sutures are considered a surgical procedure.
So we may want to work with legislative council on that. Sutures, we are not intending to exclude sutures, but we are asking this committee to exclude cesarean section.
So the difference between sutures and an episiotomy.
Yeah.
Repair.
Well, episiotomy would not likely happen in a freestanding birth center.
We could though.
But a chair could.
Easier.
I would think that you would want to speak to someone who has
Yeah.
at least some training in this subject beyond
Yes.
my own experience, but I do believe that an episiotomy can need to happen in certain situations, and we wouldn't want to preclude that.
Okay.
But we want to be clear that, and maybe it's just a birth center does not offer epidurals or
Cesarean.
or cesarean sections. I mean, maybe we can be even more precise about what we're talking about. But we want to make sure that the scope of the procedures is constrained so that the types of narcotics and medications that are within the birth center are constrained. That is important to our office and this gets into my next point, which is at this point, and the Office of Professional Regulation does not think that there needs to be a hospital pharmacy at the freestanding birth centers, given our understanding of what types of services are being done there. But for all of our hospitals, they have pharmacies, and the pharmacies are licensed through our office, are inspected by our office. They play a really critical role in the delivery of healthcare services in the hospital setting. The majority of all medications that are prescribed, dispensed, and used in the hospital go through the hospital pharmacy to make sure that it's a clinically appropriate for that patient. So it's a very important step to ensure patient safety. They also play a really critical step in making sure that the drugs that are in our facilities are maintained in the right way, are taken off the shelf when they expire, and are not being diverted, which is a really important piece. So our understanding, again, going back to low risk, no, I'm going to stop saying surgeries, no cesareans, no epidurals. That's our understanding of what the freestanding birth centers are. The Office of Professional Regulation is not recommending that you create a hospital pharmacy within these birth centers. We understand that that would be extremely burdensome, probably cost prohibitive. But our second ask related to proposed amendments is just that it's clear in the language that when VDH is doing rulemaking around this freestanding birth center, that the Office of Professional Regulation, specifically the Board of Pharmacy, is consulted to make sure that we have an understanding of what types of rules are going to be put in the birth center, specifically with relation to storing and dispensing medications. And this is cumulative to work that we've been doing for quite some time. We had a multi-year stakeholder group with lots of different types of professionals talking about the brown bag and white bagging that's happening in clinics and clinics and doctors' offices without pharmacist review. And that is of concern, and we need to continue that conversation. It's an ongoing conversation, but we want to make sure that the birth centers are also part of that conversation, understanding that they will be storing and dispensing some medications.
Yes. Were you able to connect with any other states that are doing this about their processes around medications?
We did not.
How many birth centers do you actually think we're gonna have in Vermont?
I haven't researched it from an economic perspective. I've heard other people say one or two. But I do know that we have people in Vermont who are leaving Vermont to find these services. And I also know that we have a considerable amount of people who are giving birth at home. So I imagine that between the people who are leaving Vermont to go to a birth center and people who are having a birth at home, but would choose a more structured environment for a whole variety of reasons, would be very interested in a freestanding birth
Do you
center.
know how many people are leaving Vermont for a birth center, or how many people are actually having births at home?
I don't know those numbers off the top of my head.
And do you think you'll require more workforce for your agency to monitor this, to regulate this?
Well, we are not the regulator as it's currently written, but we do anticipate that it will be an enticing thing for some licensed professionals. So maybe we'll gain one or two professionals into our state as a result of one of these centers being stood up. But we already regulate pretty much everyone who will be working in a freestanding birth center, with the exception of the allopathic obstetrics and gynecology physician. So I don't think that will add a big licensing burden to us. And I don't see a high risk of this adding more unprofessional conduct complaints to our workload either.
Leslie, and I just wanted to flag, I think you had something else in your written testimony
We do.
around, okay. Just
If you
wanted-
want to go through that, I can ask at the end.
Okay, I'm going to turn it over to Jen then.
Sure, thank you. We did have some technical concerns with the S18, and we've kind of flagged some language where we think some amendments might provide added clarity. So you can see that first bullet on page 3, section 2351, subsection 2, defines a certified nurse midwife as a professional licensed in accordance with chapter 28 of title 26, subchapter 2. And that subchapter includes all nurse practitioners. So not only those with specialized midwifery training, but all APRNs. So we recommend changing the definition to certified nurse midwife means an advanced practice registered nurse with specialized training in birth, childbirth, newborn care, and reproductive care. So we're just trying to ensure clarity around the idea that not all APRNs are included in the definition. It's those with specialized training. And then you'll see the second bullet. We've got a couple of different definitions that are a bit confusing. So the licensed maternity care provider in 2351.5 and the licensed provider in 2351.7. It appears that the licensed maternity care provider is used to provide clarity around who can own a birthing center, but it's not clear in the language if those are the only folks who can own a birthing center. So we weren't sure what the intention was around that. And then licensed provider seems focused on professionals with that perinatal and obstetric scope of practice. It lists certified nurse midwives, licensed midwives, naturopaths with the with a natural childbirth specialty. The term licensed provider is used twice in the statute, once within the definition of licensed maternity care provider, and then again in 2360B, which provides that individuals providing non-birth center care in spaces adjacent to a birth center must stay within their scopes of licensed practice. And that second use seems in tension with the definition because that second definition is around individuals who are not within that specialized scope of practice. So we didn't suggest language there. Hang on just a moment. Turning to the last page. Neither of those terms are used within the bill to limit which professionals can work at birthing centers. So we're hoping that there will be some clarity around those definitions and maybe putting those definitions into one. We're not suggesting revised language because we weren't clear on the intention behind them. The other thing that we wanted to flag, certified nurse midwives are a subset of APRNs, and they have specialized training. All certified nurse midwives are APRNs, but not all APRNs are certified nurse midwives. So listing them separately is a little bit confusing in the context of the bill. And if the intention in the bill is to include women's health nurse practitioners, which is that subset of APRNs, then our recommendation would be to expressly include them in the same manner that certified nurse midwives are. And then our last point was just that doctor of nursing practice is called out in one of the definitions, and that's a doctoral degree. That's not a licensed credential. So our recommendation there would be to strike that language.
Now I'm getting an understanding of all the occupations that you regulate. Any questions? Leslie, did you want to?
Yeah, I was just curious if you had received any complaints regarding home births, through the midwifery pathway.
We absolutely do.
And can you tell us a number, or is that?
We'll have to follow up. We'll have to.
And I don't know what the denominator is, so trying to get some context, because I know people are worried about bad outcomes, and how do we get a sense of that?
Well, so I can't provide the concrete numbers right now, but we definitely will. But when the profession of lay midwives, or now midwives, was when that started to become regulated in this state, there was a lot of testimony looking at the Sunrise reports. I'm familiar with those, with some of the legislative language around and filed testimony around why this should be regulated. There was a lot of testimony that providing a structure, providing some concrete training would be a benefit to Vermonters who want to give birth at home, and providing a pathway for people who want to give birth at home. The reality is there are people who are going to give birth at home with a professional who's licensed or not. And the outcomes are better when there's somebody who's with the laboring person at home and is able to do a whole host of things, from, making sure that that person, has the vitamin K, all the way to recognizing that there's a problem and helping that family decide to transfer to a hospital. And we get a report in our office if there's any adverse outcomes from home births, and those are reviewed. And there's a robust process around that. The majority of things that didn't go as anticipated were made better because there is a midwife in that space. I think this is a really important profession for Vermonters, and certainly at OPR, a profession that we take a lot of pride in regulating and making sure that midwives are able to provide their services in the best way possible to Vermonters who are going to give birth to children at home. I do think that there's Vermonters who currently give birth at home, who will choose to give birth in the freestanding birth center. But there will always be Vermonters who choose to give birth at home.
Sorry.
I just want to add a little context too, that there have been issues with certified professional midwives, and there have been issues with all professions. There have been
Correct.
Issues with nurses, that
Oh,
issues
yeah.
with pharmacists, there have been issues with.
Right.
That's why we have OPR.
That's right. We're very proud to be in that role, but yes, I should have said that first because I don't want to make it sound like midwives are an anomaly. They are not. And in fact, I think per capita, they probably are less we have less instances of complaints and less instances of unprofessional conduct prosecutions. Now, when we do, it's almost always something really sad and something hard. But those are anomalies.
Any other questions? Oh, Pepper?
Could you talk a little more about ownership of a birthing center?
Sure. We probably don't have a strong opinion about who should own a birthing center, but we are recommending some clarity in the bill around that, the term that's being used, licensed maternity care provider, in contrast with licensed provider. We are wondering why one is different than the other, and if the licensed maternity care provider was supposed to restrict, think about a Venn diagram, right? There's the licensed provider, which in this bill is people who are working at the freestanding birth center. Is the licensed maternity care provider supposed to be a subset of the people who are authorized to work in that freestanding birth center, or are they one and the same? I would rely on general counsel, I keep saying general counsel, legislative counsel, and, more active proponents of this bill to clarify which is which. We're just issue spotting that, defining licensed provider, we always look at because licensed provider is everywhere in the statutes. But it makes sense to define licensed provider in the context of this bill in this section of the law as the folks who can be providing care within the freestanding birth center. But licensed maternity care provider is a new term in the law, and we weren't clear whether it was intended to be a special subset of the licensed providers or whether it encompassed all of the licensed providers. And Representative, the licensed maternity care provider is who is authorized to own and operate a birth center.
Okay, that's my point. Could I own it if I'm not a licensed provider?
I don't believe so. But I would rely on legislative counsel and the proponents of the birth centers.
I think we were wondering whether it was exclusively the licensed maternity care providers who may own one, or if it was broader than that. I think we just weren't sure.
At this point, sorry to say, I'm not sure now. I don't understand why I couldn't own it and provide correct staff and do the job.
I think under the language, if you could, Jen Carvey, legislative counsel, if you could demonstrate that you were able to operate the birth center in accordance with the Department of Health's rules. I don't think the language prohibits it. It just specifies that it may be owned by, independently owned and operated by a licensed maternity provider, but it doesn't say it must.
Now, that's clear to me. Okay,
You can open this.
well.
I'm sorry.
Well, I was getting the feeling that the only person
Yeah.
that could own it was somebody who was licensed and so on. And there might be occasions where a layperson may own the business, but they don't do anything there. They just own it.
And I think that's why why the question of why add the term licensed maternity care provider came up for us is, if it's not a restriction,
Sure.
then why is it necessary to further define that? And I think that definition is being used to talk about who can operate and manage and who can own. And if all the licensed providers that are currently being defined in this bill can operate and manage, then we would recommend collapsing those two definitions.
You could start a private equity firm and then start up a.
Oh, I'm not gonna.
All right, we're conflating too many bills in one. Any other questions? Thank you. Thank you both. And we'll see you in a few minutes.
Sounds good. Looking forward to it.
Sarah, you want to come up?
In Woody, there were, in 2022, there were 176 home births.
Morning, Sarah Teachout with Blue Cross and Blue Shield of Vermont. I brought some information about our members' experience and where they're giving birth, and then some suggestions on just one piece of the bill. We did not testify in the Senate, so you know. So of our members last year, 7 gave birth at home. 8 gave birth in birthing centers. So Blue Cross and Blue Shield of Vermont contracts directly with 2 birthing centers in New Hampshire. And 3 of those births were there. And then 5 were with other birthing centers that we don't directly contract with. And then the remainder, 1,115 births were in hospitals. So that's just our experience. We certainly don't have a perspective across the entire population.
So that was 8, sorry, that
8, yes,
and over 1,000 in the hospital.
yes.
Small number.
At least for those with Blue Cross and Blue Shield of Vermont insurance. So the concerns that we have are on page 8, section 2 of the bill, where you have midwifery coverage and then comma home births. And I'll be honest, when our contracting people looked at the language, they also looked at existing law a little bit more closely. So that does happen. Our first and most biggest concern is with the clause at the end of 2, including birth center facility fees. We just don't know why you would mandate health insurers paying additional fees.
I'm really sorry. Can you cite again the page and the?
Yeah, I've got the little teeny bill, so it could be on a different page. It's section 2, section 4099D, and I'm down at A2. And there's a clause at the end of coverage, and it says including birth center facility fees. Do you see it?
I do.
Okay. So we really would prefer if you strike that. That's our number 1 ask. Our second sort of question, and you can think about it, is when we were looking at the midwife section above in section 1, we would prefer you don't have the clause and provided in hospital, birth center, and other healthcare facility or at home. We think that's unnecessary. And what we do is we contract with the midwife, and she or he may or may not work for one of those facilities. So what's happening here is mixing coverage with contracting. And for us, that's a concern. And it's the same with section 2. Probably elsewhere, I'd have to look it up in the bill, you require health insurance to cover prenatal, maternity, postpartum, and newborn services. So requiring it again here for birth centers seems repetitive. And what we're, again, concerned about is mixing coverage with contracting. We already have, fairly broad coverage requirements. And then we have network adequacy requirements. So we have to cover services so that all our members can receive them. And some of this seems unnecessary. And I'm happy to talk to Jen. Maybe she has other reasons for it, but that was our concern when we read the bill. Other than that, we're supportive of what you have here.
Have you got those recommendations in writing?
I will do that. Sorry, I got an email this morning.
It's still not clear.
Yeah, me
Sure, I'm not clear
Sorry.
either.
What that means.
Sure. So we think you should mandate, if you want to, coverage for all of these services, prenatal, maternity, postpartum, newborn services. And then separately, if you want, require us to contract with these types of providers. But right now it's mixing what we need to cover and who we need to contract with, and then adding sections about contracting. So we think elsewhere in statute, I'll try again, and if not, I'll write it down. Elsewhere in statute, health insurers are required to cover prenatal, maternity, postpartum, and newborn services, right?
Somewhere else.
Already required, I'm sure. So why you would additionally include that in the fact that we have to contract with a birthing center, which will have in the statute what they're allowed to do, seems odd.
So what's the
But what's
difference
the problem with
between
it? Yeah.
contracting and covering services? So do you contract with the hospital to then cover services at that hospital?
Yes. Yep.
So
And then we separately contract with the providers if they're not employed by the hospital or the facility. You know, that's where we have professional services contracts. So there are people who offer services in a hospital who aren't employed by the hospital directly. So we have to have a separate contract for that.
And then in addition, you cover the services provided by that provider that you contracted with.
Right. And it doesn't matter where, you know, so when we contract with a midwife, it doesn't matter where they're providing the services. That's why this clause in hospital, birth center, and healthcare facility and at home is a little bit unnecessary.
Aren't we really just saying that if you're going to contract with a nurse midwife, you have to, your contract has to include, regardless of the setting in which they deliver.
Yes.
And we're just adding birth center to clarify that that's now also included because we're putting in a definition of what a birth center is.
Right. And because you've listed it all out previously, now you need to add birth center because you would be excluding it otherwise. So again, we don't think it's necessary.
I'm concerned though more in the section 2.
Mhm.
By eliminating the including birth center facility fees. Because if you contract with a certified nurse midwife, you would also contract with a facility that I'm sorry, I said they, sorry. That they are actually delivering with, you would have a contract with that facility and you would pay that facility a facility fee. And if it was a home birth, there is no facility fee. So we're not doing that, but a birth center would have a facility fee. So if we're going to have that, you have to, if you're contracting with a certified nurse midwife and they're choosing to practice in a birth center, don't we also have to put in there that you need to start contracting with the facility? Right. And if you don't want to contract with the facility, then that's fine. They're only going to get the fee. But if you do,
This is the problem with putting contracting language in statute. You have to game out every situation. The midwife, whomever is doing the birth, may be employed by the facility. They may own the facility, or they may just go in and have a consulting arrangement with the facility. Those things have to be worked out separate in contracts. And that's why we would prefer you didn't add contracting language in statute.
I think, talk to
So
legal counsel.
we say that Blue Cross Blue Shield will contract with.
I think a willing birthing center. I mean, the other thing is if there's only one here in the state and they don't want to contract with us, you're requiring us to contract with them. It just.
All right. Do you have any examples from how New Hampshire handles this?
So we voluntarily contract with the birthing facilities there because our members want to go there. We don't have, there's nothing in state law here or there that says Blue Cross has to contract with them. I could look it up. Sorry, that wasn't really answering your question.
Any other questions? I have one.
Okay, not done.
You have 2 contracted birthing centers in New Hampshire.
Mhm.
What is the difference in Blue Cross Blue Shield's reimbursement between how much you pay for the facility fees for those birthing centers as compared to, on average, what you pay a hospital in the state of Vermont?
So I don't have the number memorized, but it was in the cost comparison sheet that I provided to the committee, and I can email it to you again. Yes, that one.
Okay,
You have actually, if I may,
yes,
your freestanding facility was $2,870. That's for a vaginal birth delivery. Compare that to UVM at 17,100. Dartmouth was 11,582, and a community hospital is 6,904 versus freestanding $2,807.
and just to be clear, that's just the facility portion, that's not the provider.
I think there's notes there at the bottom about what it includes. Because our data team was trying to be careful. It says inpatient facility cost only. And it's also for, I think they were trying to compare what's the term you're using here? Low risk. Right? So that's not mixing high risk birth with low risk birth.
And facility only, not
Facility only, so not professional fees.
Okay. Thank you.
Thank you.
Sarah. We have Pam Torta?
Yeah.
Oh. Sorry, I don't think we've ever, I can't remember Dale ever coming in. Why did we-
Well, I haven't been here in years, so for the record, I'm Pamela Coda. I'm with the Department of Aging and Independent Living with the Division of Licensing and Protection and the State Survey Agency Director for Vermont. So we also did not testify on this bill in the Senate. So the Division of Licensing and Protection, backing up. We are here because the Vermont Department of Health has indicated that we will be doing their inspections for them for this freestanding birth center. So they have the licensing obligations, but we will be handling the inspections of the facility. So it sounds like there was a couple of questions that came up about that. So I'm just here to provide some information. So the Division of License Protection Survey and Certification Unit, which is us, we are the Centers for Medicare and Medicaid Services Survey Agency. So we certify the healthcare facilities in Vermont for CMS. We also license state providers. We currently have 17 nurse surveyors in the field who inspect 15 different types of facilities and providers. Each provider type has a different set of regulations and also their own survey process. So our staff are accustomed to surveying multiple different provider types. We support Vermonters having a choice on where they give birth and would be willing and able to conduct the survey work for the Department of Health in regards to the freestanding birth centers. Currently, we conduct their state hospital licensing work for them. We do that under an MOU, so the structure already exists to add on to the licensing work we do for VDH currently. In our work overseeing hospitals, we evaluate labor and delivery units for compliance with federal and state requirements, with 5 surveyors currently trained in that work. The frequency of the routine relicensing surveys for this provider type isn't clear, and we can't predict the amount of complaint investigations that will be needed, so I can't speak to specific amount of resources, but we're confident that we can support this work for the estimated 1 to 2 birthing centers. Also, in speaking with other states in our region, there is a very low complaint volume for these freestanding birth centers. So we don't anticipate a large amount of additional complaint work with this provider type. So in conclusion, we support this bill and we're confident we'll be able to provide the resources to conduct surveys on behalf of the Department of Health. I'm happy to answer questions.
Anyone have any questions? I know that there was a lot of questions around who does these inspections, qualifications, and what are they looking for? Is there? Yeah, go
I
ahead.
was the one that used a very terrible example of wanting to make sure it wasn't a plumber that was doing the surveying of license, the freestanding birth centers, but it sounds like, and I've had experience in a long-term care facility working with nurse surveyors, and even though it was unnerving, it was a really good process. You do unannounced.
All of our visits are unannounced.
Just if we could get a copy of your.
Yeah, sorry, I just, threw
That would be helpful. Thank you.
Send it along.
Thank you so much.
All right.
Thanks for coming in. And Laura. Hi.
Hi. My name is Laura Bellavo. I'm a staff attorney with the Green Mountain Care Board. I work on a certificate of need, also insurance rate review and public records. And I have been here before, but I don't think I spoke for too long then. And I'm here, I think, to answer some questions that may have come up about the interaction of the freestanding birth center bill with the CON H96. And legislative counsel, Attorney Kirby, had asked me a few questions. I'm happy to summarize our responses. And so there was a question of whether to completely exempt birth centers from the CON subchapter. And I'll say the board does support exempting birthing centers from the CON subchapter. In terms of wording, right now it's tacked on to the end of the healthcare practitioners exemption. And we would prefer for it to be a separate, its own exemption. We had issued an opinion a few years ago stating that it didn't qualify for the physician office exclusion. And I get it would kind of call into question that decision. And part of that is we have a series of precedents about what is and is not a healthcare practitioner exemption. So we would prefer, we're fine with it being excluded, but we prefer for it to have its own because it's a different type of facility. Then if we, and then there was a question of not exempting it because it appears that the monetary triggers are going to be so much higher for CON review, but I think the board is comfortable with exempting them from the subchapter. And then the question came up about the transfer of ownership. And honestly, we would need some more time to consider that issue. And it appears that there's other legislation in the works about looking at transactions involving healthcare facilities. And so it might make sense to include birthing centers in the consideration of that. From a pragmatic perspective, there isn't going to be a transfer of ownership yet. It will take some time for the bill to pass, for there to be a birthing center, and then for it to have a transfer of ownership. So we think taking some time to make sure that that is being done correctly might be a preferred course of action. And if not, if there's a desire to address that issue head on, we don't have, again, it's part of a bigger question. So we would want to see wording before we were able to take a position. So that's the extent of what I had prepared for today. I don't know if you have any other questions or if I can be of assistance.
Oh, Topper. I
If-
keep looking at Woody and Woody's like not raising his hand, but I can see the question. Like his eyebrows are raising. So, but let's let Hopper go and then Woody.
Maybe you could help, at least me, understand the transfer of ownership concern. If we're exempting birthing centers from C1 process, and we're doing that separately, what's the concern about transferring ownership?
My understanding is that there has been conversation in these rooms about what if a bad actor, I think that's literally the words that have been used. I don't have a more sophisticated legal way to express it, but there's concern of someone came in to purchase it, you know, I think we say private equity or venture capital, and I don't have more detail about
Okay.
that, but that is kind of the concern, that you're taking something and having, you know, a much larger entity owning it, maybe from out of state. You may not be managing it the way that would be desired. And I think that is part of that larger question that's in the pending bill about looking at transfer of ownership of healthcare facilities.
Yes, please.
So the questions that I had sent to Laura were, does the board think there should be a full exemption from the subchapter, or is that not necessary, from CONs, or is that not necessary because of the monetary threshold? Or is it not necessary because of the monetary threshold, but there were concerns about transfer of ownership? So I think if you go with the board's suggestion of just excluding birth centers from the whole subchapter on certificate of need, then it also excludes them from any transfer of ownership CON requirement. You're just saying no CON. So I think what Laura's answering for you right now is if you did sort of a middle ground where you didn't do an exemption, but you wanted to carve out birth centers from the transfer of ownership CON requirement, they would need more time to think about what that looked like. But if you're thinking of excluding them from the whole subchapter, you don't have to look at that issue right now. Is that accurate?
Thank you. Yes.
Yes, sorry, I threw you questions and then you tried to answer them.
And if we did do that, your recommendation is that we don't include it in the pre-existing 9435. We have a separate line.
It would go in 9435, but the way it is right now,
Yeah.
it's put into an existing subsection that
Yeah.
talks about individual practitioners' offices. They would like a standalone subsection in that, still in 9435.
So we'd have an A and a B.
Well, you already
Or-
have like A through H, I think we
okay.
put I in
Yes.
that H 26. So it would go somewhere in that
Okay.
list of subsections, or just to standalone, which I think makes sense.
Exactly.
Okay. Any other questions? Oh, Woody, I'm sorry.
Other questions?
No.
Okay. Yeah, I have a couple. Will the board be monitoring costs for birthing centers? Will you be looking at its budget?
If they are exempt from
Then
CON
you would.
review, then no.
Okay. So if a birthing center, an established birthing center in the future, is having financial problems, that is something that the Green Mountain Care Board will not be overseeing or looking into.
Directly, no. Or perhaps in the guise of, insurance rate review. I think tangentially, but without CON jurisdiction, and without them having, being reviewed in the hospital budget process, which I'm not hearing would happen, I can't envision a direct oversight.
Very good.
That'd be equivalent to an independent primary care practice that you would not oversee. Because there are many things that you don't oversee.
Exactly.
Yeah.
Yes, I would say that based on my understanding of the statutes, that would be the case. It would be similar to.
Yeah.
Woody, did you have other questions?
No.
Oh, I thought you had a few. I thought Alan.
I don't know who's this addressed to, but listening to the testimony from Blue Cross, 7 births at home, 8 births centers, and 1,000 or so at the hospital. I have trouble perceiving that this center is going to be able to survive financially. And I'm concerned if it don't, will they be asking for the state to help finance these companies?
Can I make an analogy? Because I've sort of gone, when I'm been thinking about this bill. If a dentist moves to town and decides to open up his own dental clinic, and there's not enough people, which we know there are, but if there wasn't enough people and he has a bad business plan and he goes out of business, would the state have to come and step in and save his dentist's office?
Well.
Only if we wanted to.
Well, we don't have any legislation to do that.
I mean, we
I
don't,
understand that, but
we don't
this
say
is,
private entities.
that's right, we don't. So, and maybe it's not, shouldn't even be a concern. But with how many, has there been a study done on how many potential people that will be using this 1 or 2 birth centers?
It hasn't been made available. Like, I think once, when you build it, they will come.
Okay.
That's my opinion. I know a lot of younger people that would love this. They just don't want to go into the hospital. So it wouldn't be anything that we would be on the hook for except to.
But we've been told here that they won't compete with the hospitals.
Yeah,
That's right.
Well, I just heard that a lot of people that went to the hospitals would consider this, so I'm just confused a little bit, so we'll see.
Lori?
I would just say, I think we've heard testimony and I know we've gotten flyers in the past, that this happens in almost all other states. It's happening next door in New Hampshire. And it is what a portion of our population wants to have. And so I don't think we should be concerned about whether or not we have to bail them out later. We don't even have one yet.
True.
Lori?
to continue on with your dentist example, we don't police or oversee if hardware stores have a good business plan or other private entities. So it concerns me that we're considering that that women's healthcare is something, again, that needs to be policed when women's healthcare is already being policed way too much. But that strikes a little bit of a.
Well, you know, we're talking about different businesses. We're talking about healthcare here.
Yeah,
And we've all talked about healthcare here being pretty much in a crisis. So I am concerned about making tough decisions and looking out for the financial aspect of it. So it might not even be a concern.
There's many healthcare private entities that we don't inquire about whether they have solid business plans or practices. That feels paternalistic to me.
Any questions for Laura? Can I bring it back to the witness in front of us? Any questions for the Green Mountain Care Board? Thank you. Hopper, do you have any questions?
Nope.
Or did you have a
statement.
statement? Yeah. Absolutely.
Correct me if I'm wrong. My understanding is this bill allows a birthing center to take place. Period. It may never happen.
Mhm.
Am I correct in that?
Currently, we have no process to be able to license a facility like this.
Yeah,
This
but if
creates,
somebody wanted to
this
do it.
creates a license for someone to be able to open one.
Right.
Yeah.
And if they're gonna open one, they're certainly gonna do a survey of who will be able to come in, how many there will be, there'll be a business plan, all that kind of stuff. So my understanding is all this does is provide the ability for a person to do it and be licensed.
To open a business. Any other comments or questions or for each other?
I have a comment. We've also heard that these birthing centers will probably not have an effect upon hospitals, supposedly. But I have received some email letters with a concern that if birthing centers start to come to Vermont and start multiplying, that it may actually have a direct effect upon our hospitals, our OBGYN clinics. Whether or not that will happen, I don't know, but it is a concern that I am receiving emails about. So I just passed that along. But with our testimony, we've heard that it should not have any effect upon our hospitals.
I want to remind everyone that in the bills, there's nothing that precludes an OBGYN from delivering at a birthing center. They're professional, so it might even give OBGYNs another option of, the facility that that the patient requests. Okay, let's move to S28 because we have Secretary of State's office here. So Lauren, welcome. Welcome.
Yeah, we all have them.
Well,
That's my question about, I thought, why not set up one?
Yeah.
That is sort of where, if there's a gap in service, but they could.
Attract more business.
Exactly. These numbers are all too close, 18, 28, 27.
I know. I keep hitting the wrong
The Senate sent us way too many bills with like numbers. I'm having a difficult time myself.
Thank you.
Welcome.
Again, for the record, Lauren Hibbert, Deputy Secretary of State, and I have with me.
Jen Colin, General Counsel for OPR.
Thank you so much for having us in to testify about S28. We are very supportive of this bill on whole. And of course, I hope it goes without saying, but the Secretary of State and the Office of Professional Regulation are committed to protecting healthcare services for all individuals within our state, particularly those that will be affected by this bill. We're going to go section by section and just talk about our support, or if there's recommended changes, feel free to ask questions at any time. Section 1, the public records exemption. We strongly support this section of the law being changed. This will make exempt from the public records section, meaning what we have to release to the public. Some of the very sensitive contact information for our licensees. Currently, we have to give the public address and we are giving email addresses. This expressly says, and we've determined as an office that we do not give out telephone numbers because there's currently a section in the law that says that we should not provide publicly information about our licensees that someone could use to harass and annoy. And we've decided telephone numbers are in that harass and annoy bucket, but emails are not. And there really has not been any litigation around this topic or any guidance outside of what's in the law. So we support this because it will mean that we do not have to provide email addresses to the public. And we are asked, just for context, the Office of Professional Regulation is asked for lists of our professions, including email, probably at least 4 times a week. And these can be requests from marketers of all sorts of services, continuing education, and other services. It can be someone who's trying to find the contact information of a specific individual. It does expose our licensees to amount of risk and harm. So our process is whenever someone applies or renews, they provide a public address, their mailing address, and their physical address. And we already do that. And this clarifies that we only have to provide the public address. It is important that applications do remain public. So we appreciate that this strikes the balance of excluding some pieces of an application, but not the entire application. This will, when we have to release a licensing application or a renewal application, this will mean that we have to do additional redaction, but we don't see that as a significant burden for us.
So moving on to section 2, the truth in healthcare information section. That section adds false, deceptive, or misleading advertising about healthcare services and other requirements to OPR's unprofessional conduct statute that applies to all of our professions. That's in 3 VSA 129A. So there were several changes that we very much support. Adding advertising about healthcare services that is intended or has a tendency to deceive or mislead, adding that to our unprofessional conduct statute, we very much support. Adding delivery of healthcare services to unprofessional conduct statute related to delegation of professional tasks, we support that. And adding the requirement for active oversight by professionals who are delegating, who are allowing their names and licenses to be used. Essentially, if they're not actively overseeing the tasks that have been delegated, then that is deemed unprofessional conduct. So we like that. We like those additions. In 3 VSA 129AA6, some language has been added, any combination of, and we're asking that that be stricken. And let me just, AA6. Okay, so that's where it says delegating professional responsibilities, including the delivery of healthcare services to a person whom a licensed professional knows or has reason to know is not qualified by any combination of training, experience, education, or licensing credentials. So we're asking that any combination of be removed. So we have cases, active issues that we're looking at where licensed individuals are engaging in dangerous medical activity without medical licensure and without, meeting all of the necessary training credentials, qualifications. So those individuals are arguing that they are qualified by virtue of training alone, and that activity therefore can be delegated to them by licensed professionals. So that any combination of language we kind of felt would strengthen their arguments and make it harder for OPR to protect the public from unskilled and unlicensed medical practice. So that's why we're asking for that to be stricken.
Do you have alternative language?
We're simply asking that it be removed.
Okay.
And it's hard. So there are a few language tweaks that we wanted. So on page 3, we put the statute in with the changes that we'd like. So we'll take a look at that in just a sec. So we also propose adding language to clarify that a licensed professional cannot delegate responsibilities that would expand a licensee's scope of practice. And that's really important. All of our licensees have a very firm kind of scope of practice. So just making sure that they understand, that our licensees understand whether they're delegating or they're being delegated to, that they have to stay within their scope of practice, and delegation doesn't change that. So So if you look at the next page, then we've kind of reproduced the section that we're talking about, section 6. And so section 6 is conduct that could be deemed unprofessional conduct in the state. So it's delegating professional responsibilities, including the delivery of healthcare services, to a person a licensed professional knows or has reason to know, lacks licensing credentials to perform them, or is not qualified by training, experience, or education to perform them, or knowingly providing professional supervision or serving as a preceptor to a person who has not been licensed or registered as required by the laws of that person's profession. And then added language, delegation may not expand the scope of practice for a licensed professional. A delegating licensee shall be liable under this section for the actions of the individual to whom they delegated professional responsibilities. So in other words, if you're delegating your own professional responsibilities to another person, you're going to be responsible for how those professional responsibilities are done by that person you delegated to.
If I could just add something there, Jen, when we were reviewing this, we did look at the Board of Medical Practice, and they have that last section, they have in their law already. And that is just a missing piece that OPR has not had, that responsibility for acts that are delegated. And we are asking for it to be added. I think it's been implied for quite some time.
I didn't know that was not in there.
It is not expressly in there, but we have been operating like that is true. We just would like that to be added to the language so it's expressly clear.
Yeah, we have had unprofessional conduct cases where we've kind of argued that in the enforcement unit, but to have it explicitly stated will be a help for us in protecting the public. So you'll see also on page 3, sections 3 through 5, and section 6, OPR supports those changes. There is a note about section 6, just changing the term woman to patient in 18 VSA 5222B would be more gender inclusive. So we just noted that.
We identified that too.
Oh, okay.
Oh, good.
Okay, great.
Are there any questions on those sections that we've talked about so far?
I have a question on your recommendation above around unprofessional conduct. So it's my understanding a preceptor is essentially, if you're doing like a clinical rotations or something, it's the person that you're working underneath. But oftentimes if you're in that role, you're actually not licensed yet. So because you're still in the education phase. So if we included professional supervision or serving as a preceptor to a person who has not been licensed, and then that person does something, but that person wouldn't have the opportunity to be licensed yet because they're still in the education phase,
So
right?
that the preceptor language is currently in the law.
Oh, okay.
And we have different models where some people do preceptorship or supervised practice when they're not licensed, they're in school, but we also have professions like the mental health professions where you have to be on the roster of non-certified, non-licensed practitioners to do licensed supervision like that preceptor. So we have, and that's why it's really important that it says as required by the laws of that person's profession, because across all of our professions, we have sometimes people are receiving professional training and supervised practice or preceptorship without the requirement to hold a license. And in other professions, you are required to hold a license. So the way the law is currently structured, it's just if you're required to hold a license while you're receiving that supervised training or preceptorship, then that person has to have it in order for the preceptor to be doing their work.
Okay, thanks.
Yeah, of course.
Oh, Pepper, sorry.
We ran into this in another bill, so. On that language that you're talking about, would it be appropriate to have a cooperative agreement between the practitioner who's going to be supervised and the one that is being supervised? Would that just solve the problem?
In some of our professions, that is required, and some it is not. And I think this section arguably covers a much wider scope of what's happening in the field than those more structured agreements like the collaborative agreement or the, I think this covers a lot broader universe of what's happening. We anecdotally don't have a lot of data. Those cooperative agreements frequently help. They can also cause controversy or tension, but they are helpful to clarify what's going to happen in the course of the agreement.
But to require one in every profession where there's some kind of supervising relationship, I don't think that's something we've studied or looked at. That seems like it would be very burdensome, but we would probably need to kind of figure out what the impact of that would be. It would be big.
Huge.
Okay.
Because this type of delegation is happening in really large ways and really small ways all across the healthcare industry. But what is really important to OPR is just that when, let's say you're a nurse and you're delegating something to an LNA, one, that you're not delegating something to an LNA that is above their scope of practice, and two, that you understand how you're delegating. And nursing, that delegation happens every day, all day, with multiple people, multiple times during the day. So, and that profession has worked this out really well. But, let's say you're a nurse and you're delegating something to an esthetician, or you're a nurse and you're delegating something to, a dental assistant. Those relationships don't happen every day. And the nurse needs to understand what is the scope of practice for the esthetician, what is the scope of practice for the dental assistant. And the dental assistant needs to know that they can't be delegated something that's outside of their scope of practice.
Thank you.
We have the same concerns that Jen has outlined with sections 7, 8, and 9. But those are the Board of Medical Practices sections. So we don't have strong recommendations there. And in fact, as we were reviewing this yesterday, some of the ways that the Board of Medical Practices statutes are organized is just very different. So pieces that we're recommending in our section, we found in the Board of Medical Practices statutes. For the prescribing of medication to terminate an individual's pregnancy based on an adaptive questionnaire, we do support that. We currently have pharmacy rules that contradict that, but we are in the process of promulgating new pharmacy rules that do not include that language. So we're moving to a place where our pharmacy rules will not be in conflict with this law. So we support that, that language being added in this bill. We do want to note that it's this language we feel comfortable supporting because it's really narrowly tailored for this specific instance. And there is a compelling public health interest. So we would not be ecstatic about an adaptive questionnaire being used for other types of healthcare. But because this is this healthcare and this scenario, we do support an adaptive questionnaire. We, of course, still have oversight over the practitioners and also the pharmacies that are dispensing. So we have adequate oversight over this entire space. We do recommend adding a piece of language, which is that the adaptive questionnaire be based on a prescriber approved, that it be prescriber approved, so that it's clear that the prescribers have some input into how the questionnaire is developed, and make sure that all of the appropriate questions are asked and answered. And that, if you ask a question and the answer is one direction, that the next question is clinically appropriate. We just want to make sure that there's clinical input into the creation of the form, and think that the language would benefit from clearly expressing that.
I'm just wondering how that gets operationalized.
Yeah, me too.
Well, I think that the prescriber would have to feel comfortable with the form before they were able to use the form to prescribe.
And how's that get documented? Do you think it needs to be
I
documented?
don't think it needs to be documented,
That's fair.
but I do think that the prescriber needs to feel some agency to make sure that the questionnaire is what they feel comfortable with. And I think for a lot of the business models, the prescribers are actively involved in creating the questionnaire because they want to make sure that they are using this adaptive questionnaire in the appropriate way and prescribing in the appropriate way. We just think that it would be more protective to make sure that that prescriber approved is in the statute. Section 10, we support, and
Sorry.
Yes, sorry, go ahead.
So would the implication would be if they use the questionnaire that they approve it.
yes,
So that does it.
yes.
Okay, thank you.
Section 10, we support, and section 11, I'm going to turn it over to Jen.
Okay, so section 11, OPR does support the policy, provided that patients have the means of learning the names of their prescribers. Current pharmacy rules require that pharmacists include prescriber names on all labels. In anticipation of this section's carve out, OPR's pending pharmacy rules have acknowledged the possibility of this superseding language. So we've also learned from pharmacists that there's, speaking of operationalizing sections of this bill, we've learned that there are concerns about implementation of Section 11. OPR encourages the committee to reach out to the National Association of Chain Drugstores and the Vermont Pharmacists Association to determine the feasibility of removing prescriber names from medication labels. We don't have enough information, but have heard anecdotally that remains a problem. And then we just had a question. The bill language appears to assume that prescribing practitioners will be employees or contractors working within a medical facility, and that provides some degree of anonymity. But solo practitioners and partnerships, we're just not sure how that's what the impact is there. And then you'll see in the next bullet on page 5, OPR suggests the following minor draft revisions. As drafted, the bill says, upon the request of a prescribing practitioner and to the extent not expressly prohibited under federal law, a pharmacist shall not. And we would suggest changing prohibited to required. So it would say, to the extent not expressly required under federal law. And we're suggesting that change because the bill's forbidding pharmacists from taking an action. And then the next bullet, we suggest changing each instance of pharmacist to pharmacy professional because the labeling that's happening is not necessarily done by a pharmacist. So there are pharmacy technicians and pharmacy interns who are also doing that work.
Speaking of delegated tasks.
Yeah, really.
And then in section 12, the concerns that we mentioned in sections 2, 7, and 9 regarding delegation, we have those same concerns in section 12. And then in section 13, the effective date works for OPR, but again, the operationalizing of the labeling provisions, you may want to hear from other pharmacy professionals about that.
Any questions? Thank you.
Thank you. Have a wonderful day.
Yeah, we're moving from the Secretary of State's office to the Treasurer's office.
I cede our seat.
Invited the auditor in also today on something. It's like, good. Good morning.
Morning.
Welcome. And for the record, we're moving from S28 now to S27.
Yeah, good morning. Thank you very much to House Healthcare for having me, and thank you also for taking the time to bring up S27 as well and take so much testimony on it. Also, I caught up on the testimony from yesterday and also saw some additional folks that were testifying tomorrow. And you have a great slate of witnesses. So thank you very much. This, debt proposal, debt relief proposal and credit score protection proposal, something that we think is very important. A lot of Vermonters have medical debt. They deal with it financially. They deal with it in terms of health outcomes, being shamed to go seek more medical care for fear that they're going to accumulate even more debt or fear that it's going to have a financial impact on them, fear that their doctor's office won't see them because they owe them money. And this bill makes a big step forward in a lot of those issues, both in terms of protecting somebody's credit score from medical debt, so they're not impacted negatively by having an emergency, having a medical procedure that through no fault of their own puts them into debt. But it also works on eliminating a significant portion of medical debt for people that are experiencing that here in Vermont. And we'll run through that a bit and talk a little bit about the entity that has done this work in a variety of other states, Undo Medical Debt, and the process that they use to get to a negotiated settlement to purchase the debt and provide that relief to individual residents. But I have a presentation, and I think maybe it's up behind me. Nice.
Magic.
So I mentioned this already, but medical debt's different from other types of debt. That's why the credit score piece is so important. It's not like when you go and get a credit card and you make this intentional decision to take out the debt. And then similarly, when you buy a car or buy a home, you're making that intentional decision to take out the debt and buy the thing, the underlying product, the car, the home. You have choice. You have the ability to buy different cars, less expensive cars, more expensive cars, same with a home. You have the ability to delay buying the product if you can't afford it at that moment or you decide you don't want to pay for it. But with medical debt, it often happens to you when you have no control. You don't have the ability to say, I'm going to delay this care or delay this treatment. You don't have the ability to shop around. You're being taken by ambulance to a hospital and the procedure is happening to you. And people find themselves, unfortunately, not just trying to get better health-wise, but trying to get better financially as a result of getting into medical debt. So protecting somebody's credit score from medical debt makes a lot of sense for those reasons. And I'll mention this at the end too, but the federal government moved forward in this space, but we are worried that that regulation, I should say, will become undone for a variety of reasons. The CFPB did implement a medical debt protection regulation in December, I think it was.
EB.
Yeah, Consumer Financial Protection Bureau. Yeah. So there's worries that the Consumer Financial Protection Bureau might not exist, that the regulation might be repealed, or that legally it could be overturned. So makes a lot of sense, in my opinion, to put this protection in Vermont as well. We touched on this, but, very few people, really Americans, but also Vermonters, have the savings to buffer a shock from medical bills. A lot of folks in Vermont do have health insurance, but we still have an we have an uninsured population, but we have a growing underinsured population, as this committee is very familiar with. So when you don't have the money to meet your entire deductible, when a particular medical emergency happens to you, you can quickly find yourself in medical debt. We talk here about it being recognized as a social determinant of health, that it's the leading cause of bankruptcy in the United States. And medical debt is more prevalent in communities of color, communities that are poorer, communities that are more rural, really places that are economically distressed. People that are economically distressed are going to end up with more amounts of debt. And again, even if a provider has stopped the collection attempts, patients remember and may avoid care out of fear of more debt, that shame that their provider is not going to see them, or just an overall shame that they haven't paid the debt at all. Medical debt's pervasive. I think you heard testimony on this yesterday, but depending on how you rank it, there's 4 in 10 adults nationally. Vermont's numbers on this scale are above average. We have our own data that shows maybe it's 1 in 10 Vermonters, but it's at least a significant number of Vermonters that have medical debt. On this ranking here, we're sort of in the top states in terms of medical debt. If you think about our medical system, to me, that makes sense. We have one of the most, if not the most expensive medical system in the country, but we don't have the highest median incomes in the country. So that gap between what an average person is making and the cost of healthcare is widening in our state, which means people would be more likely to end up in medical debt. Again, just reinforcing that folks that end up in debt are those struggling with poor health and those that are financially insecure, so more vulnerable populations. The history of Undo, and I mentioned Undo at the beginning of my testimony, but they used to be called RIP Medical Debt. They're a nonprofit that was formed by former medical or debt collectors whose purpose it is to strengthen communities by erasing financially burdensome medical debt. So they're founded about a decade ago. They are one of the leading, if not the leading, charitable organizations to help individuals pay their medical bills. They have about $15 billion of debt relief for about 10 million Americans since they've been founded. In the recent past, they have had about $3 billion in debt relief in 2024 and about half a billion debt relief in the Northeast since 2018. They received $80 million from Mackenzie Scott in 2020 for their work that sort of elevated and promoted their work. So I mentioned all this just as a way of background that they are very well, they're the experts in this space in terms of the purchase and elimination of medical debt. They have a strong track record. They have experience working with all types of providers, hospitals, and otherwise. So they'd be a great partner in this work. If the bill passed, we would have to contract with them, but they're the most obvious partner in us executing on this work. And then I mentioned that they had all that debt relief from their philanthropic efforts, and those efforts actually touched Vermont. They have forgiven some debt in Vermont in the past, and they have two testimonials that they sent to us from Vermonters that had been impacted. And I just wanted to quickly read those. One is from Bobby in Richford, Vermont, who says that they received a letter in the mail about their medical bill debt being abolished, generously provided by Principal Financial Foundations. That was who was funding that. In that case here, it would be the state of Vermont, and coordinated by Undo Medical Debt. I was shocked and it touched my heart. I've truly been blessed. I was trying to figure out how I was going to pay my outstanding medical bills. Everyone who donates and helps people like me is an angel in disguise. And then Emily from Burlington says she can't believe her medical debt was abolished. She had racked up this debt when they had a mental health crisis. They were put in an ambulance. They were not properly charged by their insurance, and they racked up a $9,000 bill. They described being too sick to even deal with it. I ended up refusing to pay it because it was their mistake. I almost couldn't buy a house because of collections, having my debt abolished only a few weeks before giving birth. Just had my first baby, Stella, was amazing. I can't thank you enough. So, just wanted to highlight sort of the impact that they've already had in Vermont in a small way. And we want to take this and bring it out to a much larger number of Vermonters. We estimate about 60,000 Vermonters would fall into the category here in terms of being able to provide debt relief. And then Undo took their efforts from sort of purely philanthropic, raising money from individuals and foundations, to then partnering with states and governments. So this is just a quick list of some of the states that they partnered with. The state of Connecticut was the first that came on my radar. They had $6.5 million that they had set aside to cancel $650 million in medical debt. Rhode Island, Treasurer Diosa, I know, has been invited to testify. He came up a couple of months ago when we announced this proposal. They have a program that's similar to us, appropriated about $1 million. They think will relieve about $100 million in medical debt. Rhode Island also has a prohibition on credit score reporting as well. The state of New Jersey, the state of Arizona, the District of Columbia, the state of Pennsylvania, the state of Illinois. And then there are a number of local efforts as well, both New York City, New Orleans, Pittsburgh, Toledo, and Cook County, Illinois. Cook County, I think, was the first area that did a partnership with Undo Medical Debt as a government. So now between those states and those cities and counties are about 20 governmental units that have a partnership with Undo Medical Debt, including Connecticut and Rhode Island and New England. So turning to the next page, it just sort of talks a little bit about who's the typical provider. And I think this is helpful. This was helpful for me. I think it'll be helpful for the committee, because one of our due diligence items over the last year or so when thinking about this proposal was, well, how does it apply to Vermont? Vermont hospitals aren't for profit. They don't necessarily engage in the same debt collection practices other states may engage in. But they, meaning Undue Medical Debt, let us know that their typical provider partner is a nonprofit entity that has never sold debt, that doesn't sue or necessarily even report to the credit reporting bureaus, and has a solid patient assistance, financial assistance program. So it sounds a lot like our hospitals in Vermont. And as we've had deeper conversation with them, it does seem like our hospitals and other providers would be a good fit for the undue medical debt process, just like in other parts of the country. Their process in terms of how would it work, the bill would have to pass, and then we would have to enter into a contract with Undue Medical Debt. I believe because they are so uniquely qualified, it probably is a simplified process and not a full RFP. So that timeline could be probably done by the end of the year. And then at some point, once they're on board, our office would work with them to basically put them in touch with all of the providers in Vermont that would be interested in entering into a negotiation. So we would help facilitate their connection to Vermont and to the Vermont hospitals and other providers. And then participating providers would enter into a business agreement and a non-disclosure agreement with Undue Medical Debt to protect the confidentiality of patient information and other aspects of the transaction. They'll then send their data files to Undue Medical for analysis. Undue would execute by reviewing the files, doing a soft credit score to make sure eligibility could be determined, 400% of poverty and below, or people that have catastrophically high medical bills relative to their income. They would then make a offer to purchase the debt that they're interested in buying that meets their eligibility criteria. They come to a number, they would purchase it, and sometimes hospitals will donate the amount of debt as well, because it really is a penny on the dollar. It is pretty low at that point. So that's something that can be certainly discussed. And then the hospitals will decide to make their participation public or not. They could do something on their own. They could do something in connection with Undue Medical Debt or our office. Some keep it confidential. But either way, their patients will then be notified of the debt relief from Undue Medical Debt. They'll be sent a letter saying that their medical debt has been forgiven, similar to the letters that the two testimonials received. And I know from the healthcare advocates testimony yesterday, we're certainly happy to put information about patient assistance programs in the letter. I've seen some of their letters in other states, and I think you can convey a good bit of information in those letters. But I think the critical thing is for the person to know, obviously, that their debt has been abolished, because that's what changes those behavioral health items that I referenced earlier. The program focuses on,
Just Mari has a real quick question, I think.
I'm also looking at Boz in the room. Hospitals are required to report a certain amount of community, like giving back to the community. I can't remember what it's called. Community benefit. Would, if they donated to removing debt, would that, do you know if that would qualify under that?
Look at the Devon too.
Devin Green from Boz. I would need to look into that further, but I don't see why it would. But I'm happy to come back with more specifics.
Thanks.
Thanks for the question. That's
Yeah.
good. The program, would focus on debt that's 12 months to over 7 years old, measured from the date that the service was provided after the billings and collection process have been completed. That's why that ratio is so high, that the economic value of the debt at that point has been diminished to the point that you're buying it for a penny on the dollar. But that face value is still with the Vermonter who is experiencing, either the financial impact or the concern and the worry and the behavioral impacts of having that face value of the full amount of the debt and not seeking medical care or worried about seeking medical care or delaying their medical care. And then I guess that's the point that was just made on the next slide. So overall, partly to the question, hospital, even though it is a very small amount, hospitals will only be in a sort of net positive position, either from selling or canceling their debt. There's no negative impact to hospitals by engaging in this process. The next slide just shows how that process works in terms of a visual of what I just walked through. So I think I can skip ahead on that. And then just last is just, again, a couple of other testimonials, not from individuals that have been impacted, but from leaders at various health systems or hospitals talking about how they had a very positive experience working with undue medical debt, and how forgiving the patient debt to financially vulnerable people really highlighted for them that they feel like they're living their values and providing great patient care and supporting the community. Another talks about how it is their ability to really bring health equity to life in their community and is supporting those efforts. They all really just talk glowingly about their experience working with undue medical debt and the impact that they're able to bring to their community and to the patients that they serve. So on the last slide, just again, overviewing the proposal here, undue medical debt estimates that there's probably about $100 million that fits in those eligibility criteria. So people that are making 400% or below of the federal poverty level that hold medical debt, estimate that it's over 60,000 Vermonters. It would require certainly negotiation with the hospitals, other large providers, hospitals that are not only in Vermont, like Dartmouth, which a lot of Vermonters seek care at, potentially Albany. Dartmouth is also Cheshire Medical Center, but that's another place where a lot of Vermonters seek healthcare down the Brattleboro area. So we're cognizant of that, and it applies to Vermont residents, sort of regardless of where they seek care. And then, of course, the prohibition on reporting medical debt on an individual's credit score. We view these two things in tandem. One is looking retrospectively in terms of the medical debt. It's a one-time elimination. It's not ongoing. So I don't think it brings up these concerns that people might have about behavioral changes. It's a one-time elimination. But then on a go-forward basis, protecting somebody's credit score protects everybody and does so into the future. It's not a one-time action. The amount of money that it would require for the $100 million elimination is an estimated $1 million appropriation that's in line with the other states that have entered into a partnership, that 1 penny on the dollar ratio. And we have recommended a reallocation of $1 million that had been previously appropriated to our office for this purpose, that was originally intended to use to buy down bonds that we have not bought down for 3 or 4 years because we've been earning more money on the cash in the account than we would be saving on the interest if we bought down $20 million of debt. So it's available and or at least some of it is available. And we think it's a good use in terms of reappropriating $1 million to have a bigger direct impact on Vermonters than buying down $1 million of outstanding debt.
Raising my own hand.
You may speak now.
Thank you, Mr. Vice Chair. Does the $1 million include, I mean, because you have to pay, I'm sure there's a fee that Undue will charge, even though they're a nonprofit, but nobody does anything for free.
Yeah.
Does the $1 million include theirs, and how much do you anticipate would actually be able to be used on buying down Vermonters' medical debt?
Yeah, so the way that they will get paid is that when they have affirmatively purchased the medical debt, they'll have basically a 10% charge that will go to undue medical debt. So it's not going to be, I think, a straight 10% though, like $100,000. And I say that because some of the debt that, and they're experiencing this in Rhode Island, some of the debt, the ratio in the early days was even greater than a penny on a dollar. So they're buying even more debt than this sort of general ratio. There's some hospitals that will donate their debt. Undue will still get paid because they are administratively, negotiating and then administratively sending out the letters. But I think that million is inclusive of what they would be paid, and think we can manage that to that amount. They also have talked about other states that they've worked with where if there is a gap, they've raised significant amounts of money philanthropically. They've talked about filling in gaps with their philanthropic money.
Any questions for the treasurer? Yeah, Alan, you want to go first?
This is going to be a one-time thing. This isn't something that we're going to find money for another year to do it all over again.
Yeah, I mean, that's the idea. I mean, there's nothing in the program that is beyond a one-time action. And I think that's important. I mean, if we wanted to think about an ongoing program, there would need to be a lot more thought and detail. But here, there's not this concern about a moral hazard issue because it's people that have already had have fallen into medical debt, and likely have done so years ago. And that's who will be targeted here.
Thanks.
Yes, Treasurer, a few years ago in my home district, we had a child of an Amish family that had some heart issues and, significant health issues as a result of that, lots of surgeries. Would the population of Amish be eligible for something like this?
Yeah, there's no reason they wouldn't be.
Okay,
I mean,
just
they're
curious.
for sure. If they're owed, presumably if they were unable to pay the hospital, and they certainly would have the debt with the hospital, and then Undo would look to purchase that.
There were lots of fundraisers for the family, and I was just wondering whether they'd be qualified for this as well.
Yeah, just it's the only eligibility criteria are those economic criteria. Yeah.
But I got one more, but you did mention, if I remember right, that this company that you're going to be under contract talks to the hospitals, and the hospitals comes up to the ones that they feel that need relief.
So the way that it will work is they'll provide the entire debt file that they have, and then Undo will do the analysis of limiting sort of who meets their eligibility criteria. So there shouldn't be, the hospitals shouldn't necessarily be applying any sort of judgment call or qualitative. Yeah.
I was going to ask you about the healthcare advocate, its proposal to add the language into the letter, which I think is great because it just so happens that our patient financial assistance programs in the state are all sort of aligned at that 400% level. So hopefully, like moving forward, people will be aware that they're eligible for some sort of relief in patient assistance. But the second proposal that the healthcare advocate came to us with, and you talked about this briefly when you started, right now the proposal is just almost an invitation to the hospitals, who are all nonprofits, all have patient assistance programs, their bad debt. Is there thoughts of expanding it to, I think the healthcare advocate said that they think that probably only 40% of medical debt is from hospitals for Vermonters. What about other organizations? What about, physicians' offices?
Yep.
Would you anticipate that any of this money will be used for that, or are we just talking about hospitals here?
No, for sure. I believe that the word is provider in the bill, because that's our intent, is that, we talk about hospitals because they're large and they might hold a lot of debt, but physicians groups or other private holders of medical debt certainly eligible for negotiation and purchase. So you may prioritize larger, but that's not to say that there wouldn't be the ability for other types of providers to participate. And it is voluntary for everybody. So that's the only thing, is that those providers would have to, voluntarily come to the table to have this negotiation. But there's no reason that I don't foresee a reason why they wouldn't want to.
Any other questions? Yes, Topper.
Could you just explain a little bit more the process? And putting myself in the position, I owe the money.
Yeah.
And I can't pay it. Can you just go over it again?
Yeah.
What actually happens to the debt that I had?
Yeah. So if you're, if 2 years ago you had a procedure and were unable to pay $20,000, let's say $1,000 just to make it easy, or let's just say $100 to make it easy. So you had $100. You had the hospital reached out to you about 30-day invoice, 60-day invoice, 90-day invoice, and you weren't able to pay. They sent it to a collections agency. They attempted to call you or mail you. You were unable to pay. that was an 18-month contract. It's expired. They turned the debt file back over to the hospital. And at that point, that's when the debt would be eligible for undue medical debt. Because you've shown a period of time we haven't been able to pay, the economic value of the $100 is now down to that $1 or $2.50. It's down to that much lower amount of economic value. So undue medical debt would enter into this agreement with that hospital and say, for all your debt that's 18 months old, that's gone through collections, we're interested in those debt files. They would send your debt file to them along with, maybe thousands of other Vermonters. They would analyze it for income eligibility. And then they'd say, we're interested in buying, these 9,000 of the 10,000 files you sent us. And in total, it's, $1 million of debt, and we want to buy it for a penny on a dollar. And if they agree, the hospital agrees, then they would send over your debt. And instead of trying to collect on it, undue medical debt would eliminate it, and then notify you that it's been eliminated. As sort of the process from, when you as a patient accumulate, the debt to when undue would notify you that it's been eliminated.
Something paid off.
So that would mean that, that $100 that I owed, now I don't owe it anymore. And could the hospital or the doctor put that on like their income tax or something, saying that they didn't receive, that's a loss?
Yeah. So if they say they bought yours for $1,
Yes.
so their loss would have been $99. So it would go into a category in the hospital around bad debt, but, and they may have to revise that category because they may have written the whole thing off. It depends, but yeah.
Yeah, okay. But now
So just to help with my clarity, does that mean the hospital gets a check for $1?
Yeah, that's
That's what would happen.
Yeah.
Okay.
And again, some cases, we've heard hospitals say they might want to dedicate the dollar towards something that benefits patients. We haven't had this specific conversation with hospitals in Vermont, but other hospitals have donated and said, just keep the dollar, like we're going to still sell it to you at a $0 contract.
Thank you.
Great. Thank you.
Yeah, again, thank you very much.
I got one more question, just because people ask me. The money, the $1 million that you have comes from, you said something about cash value of bonds.
Yeah.
Can you just kind of?
Yeah. So let's say 4 years ago, we received an appropriation for $20 million to our office to buy down $20 million of outstanding bonds. We have about $600 million in outstanding bonds in Vermont. So we have issued debt a couple of times since then, but each time we've issued debt, we've looked at purchasing the bonds, and we're earning about $1 million a year in interest on the $20 million sitting in the bank account. And we would achieve about a one-time $1 million savings to pre-buy the debt down. So we've already earned like 1 million, 2 million, 3 million. We've earned multiples of that. So we've just been holding on to it instead of buying it down. And now that interest rates are where they are, we didn't anticipate executing on that authority anytime soon. So we did offer up to the legislature and to the governor's team, like if you have a different use for this money that would have a different impact or a bigger impact, then we're open to that. And we think this 1 million has a bigger impact than, just for an example, if we took this 1 million and bought down the bonds, it would be a one-time savings of about $50,000 to Vermont taxpayers. But this, I think, has a bigger impact. Yeah.
Good, thank you.
Okay, thank you.
Thank you very much.
Off of live, we'll be back at 11.